development. The goal, there are 2 million, nearly 2 million older adults, and whether it's seen at a Department of Health clinic or H&H hospital or somewhere else, Parks Department, they're getting benefits through the Department of Social Services. Our goal is to continuously expand our reach and focus on older adults. So when you think about the cabinet, it is important for us to always have these conversations. So in the development of that initiative, it was the Parks Department liaison. We have a liaison structure with our cabinet where we meet monthly, and then the principals, the commissioners and deputy mayors and otherwise meet on a quarterly basis to keep track of what's going on. But on a monthly basis, we have breakout groups. There's an aging health committee, for example, and this is where the magic actually happens. So when you say look at a particular issue, I say, of course we will. It's not a report then, it is us really thinking about what are the things that we could do first at no cost to either agency or any of the agencies involved. It's using existing resources, and this happened to be one. The older adults are over there, our clinical services are nearby, let's get them over to you. That's how that happened. And then there's some more formal agreements that are put in place to then share data and so on. So we'll be happy to come back at some point and report on how that initiative went.
I feel like we're doing a good tag team because you're totally reminding me of the questions that I want to ask because you're teeing me up for. I had a question around the cabinet actually because I'm a huge fan in finding alternative programs because I'm a firm believer that not everything has to be clinically based per se. I think there's a lot of power in peer support groups as well. And so is the cabinet discussing alternative programs that could be beneficial for older adults experiencing mental health issues? And then, in terms of other partners, is there a effort with reaching out to the faith-based communities? Because I know that in my community, in the Korean community, there's a lot of churches that are essentially senior centers. Yeah. And I feel like we need to somehow bring them into the mix. And is there outreach in that community as well for the faith-based groups?
And as you well know, there are many senior centers and churches.
Yes.
Which I've visited in the basements. So yes and yes, we are having some of those conversations. We can have more and then get more structured around it, right? I think it is go where people are and strengthen those partnerships. That's the baseline for everything we're doing. To your point about peer support, I'm talking a lot, but I might turn to my colleague or just keep going. Obviously, peer models work. We know that, right? They're not appropriate for everything. It's critical for individualized sessions to happen, and sometimes the peer models happen in groups where the clinician's there, and then someone says, well, who knows that older adult, and has happened. Here's some other things you can think about. Here's what this means for my life. So as much as we could engage and as appropriately as we could engage peers and others, I think, of course, we're committed to that.
Thank you. And then switching over more to Dr. Wright. So given the growing mental health needs of the aging population and also given the workforce shortage, are you guys partnering with, let's just say, CUNY, for example, or other local graduate schools, medical schools, to sort of help build the pipeline and train more folks to go into the field?
Thank you for your question, Councilmember. We do not officially partner with CUNY in terms of training or dedicated pipelines to train providers, but we do work with those individuals and those agencies to make sure that if there is a need, that we're available to them.
Okay. And then if there's any opportunities for trainings with different agencies, for example, how closely do you partner then with DFTA if in case there are, trainings that maybe we need to provide for not just the clinical staff, but the non-clinical staff at the senior centers as well?
Yeah, we partner with NYC Aging in quite a bit, and also because we're both members of the mayor's office, that's where that partnership really takes place as well. But we're open to more partnerships and any suggestions that are out there.
Okay, and then just in terms of, because I love data, because I think it tells a story, not the whole picture, but it tells a snapshot of a story. So, even though DOHMH does not directly operate services, the data collected guides policy and funding decisions for sure. So how is DOHMH ensuring that mental health data related to older adults is actively shared and used by other city agencies? I mean, I know obviously we don't want to violate HIPAA, but I do think that there's an opportunity to use whatever data is being collected and have that shared so that it could better inform how we deliver services. So,
Absolutely,
Yeah.
Chair. And so what I can tell you is that all of our data is posted on our website, so that's easy accessible there as well. But we also share it with our providers and the partnerships that we have in the community. You may remember that in 2019 we had a deep dive on the report for aging. So we don't do that every year, but every year we produce surveillance data, epidemiological data, and that's collected and posted every year. So it may not be as deep of a dive as the report in 2019, but certainly we are constantly publishing data and making it available on the website.
okay. And then but is there, or can there be partnership where there is data collected at the OACs that are part of the Geriatric Mental Health Initiative that then get forwarded to DOHMH? Like, can it go that way as well?
I think data sharing across agencies depends on the level of data you're thinking about, but strengthening our communication and coordination is at the core of what we're trying to do always. So depending on what you're thinking about, the answer could be yes. While you're talking data, the BOLD coalition that we've joined, looking at Alzheimer's and related dementia and other related disorders, is led by Department of Health, and I know that they've been looking at surveillance and prevalence data and so on, and just wrapped up a needs assessment as one example. And so whether it's programmatic data sharing of things we're seeing, I think that's easy to do. Other kinds of coordination, where there's a referral, depending on if it's a behavioral side or something else, that's more structured. But the Department of Health is leading a coalition focused on the BOLD coalition that Dr. Wright could talk about a little bit more. We're members, and we're looking forward to what comes out of that.
And I would just add, Chair, that we partner with NYC Aging on other things like vaccines and sharing that data, health updates, new resources, funding opportunities like RFPs, requests for proposals. And so when NYC Aging asks us to participate and partner, we certainly say yes.
And what gaps do you think exist in the current surveillance systems, I guess, when it comes to understanding older adult mental health in New York City, and what investments do you think are needed to close those gaps?
I think one thing that we could say is that continued communication amongst our agencies that are already partnering together and making sure that the data we have is accurate and up to date. It's a challenge sometimes because, like, the most recent data we have in terms of surveillance you mentioned is 2022. And so getting that real-time data, I think, is a challenge. I'm not sure about my colleague, but that's a major challenge. Okay.
So I would say maybe one of the gaps is just having up-to-date information. The Mayor's Office of OCMH, the 2024 annual report highlights loneliness and social isolation among older adults as major mental health risks. And what does this tell us about the scope and trajectory of these issues among this population, especially post-COVID?
Thank you for your question, Chair. I think the important thing is that when we look at overall mental health of New Yorkers, older adults age 65 and older actually had better mental health outcomes than the other age groups. That being said, you hit on an excellent point, and that is social isolation is a challenge for all New Yorkers in terms of dealing with mental health, especially since the pandemic. But we also looking at serious psychological distress, unmet need for mental health treatment. All of those areas, older adults are actually faring better than the rest of New Yorkers. So again, it's important, and when you think about things like clubhouses, when you think about some of our programs that particularly cater to older adults, it actually addresses the social isolation head on. And, as our colleague talked about earlier, peers and having individuals that form a community actually reduces that social isolation.
And Chair, the thing I will add is, there's some prevalence estimates, as you've seen probably in the report that you referred to just now, Ava Wong and team published, about 20% of the population meet the criteria for mental health issues, right? And that is expected to increase significantly in the next few years. It's interesting. DOHMH's report opens up with uncertainty, isolation, and loss are things that exacerbated mental health issues and experiences for all older New Yorkers. We'll say that again, right? It is uncertainty, isolation, and loss, which for older adults could be a thing, especially as one ages. And so we know it is going to be critical for all of us to ensure that we're squarely looking at mental health. And I will pull back again to say, and that includes all of the things, whether it's folks say social determinants over here, I say community care over here, we're all talking about the things that drive folks to not feel well, and how do we keep those conditions to a level, whether it's food or housing and otherwise, where, the stressors, if you will, are less. And then where there is cognitive decline that could happen with age, and you're also ensuring that you have strong connections to your clinical care, right? Your healthcare practitioner, just like we are now used to saying you should go to your routine visit once a year, and that's become something that everybody appreciates, then mental health should be normalized as well, getting that mental health checkup.
Definitely. And especially given the population, I know depression rates are pretty high. And according to the 2019 DOHMH report on health of older adults, I think the report had said about 9% of New Yorkers age 65 and older screened positive for depression. I would imagine it's gone up quite a bit. And rates were higher among women and among Latino older adults compared to white older adults. And older adults in lower income households were far more likely to experience depression than those in higher income households. So can you speak to whether those rates have changed since the pandemic, and if so, how? And how does DOHMH currently monitor and track trends in depression of older adults, and how frequently is the data updated?
Thank you for the question, Chair. So I'll answer the back end of the question first in terms of we are doing surveillance on all New Yorkers, including older adults, on a regular basis. And so that's why I said even though we didn't have a more recent report since 2019, that is updated every year, yeah. In terms of the specific about the pandemic, what we saw in 2021 was about 67% of adults in New York reported feeling socially isolated. In that year, that was reduced by 40% by 2023. So the trend is getting better in terms of that specific question that you asked. Specifically for older adults, only 28% reported feeling socially isolated, which is the lowest of all the groups that we report on. So again, although that is still a concern, it is less than the number for the rest of New Yorkers that looking at that particular data. In terms of depression, anxiety, as you alluded to, those are certainly some challenges that all New Yorkers are dealing with. And it's actually, again, for that 65 and older group, it's actually less than the rest of New Yorkers. So the outcomes are better for older New Yorkers 65 and above.
Sorry. Okay, and can you point us to where we can find the data online? The most recent one, I'm sorry.
Yes, so you should be able to get that from our website. Maybe. Oh, the Epi Data Briefs, I'm sorry.
Okay.
Thank you. The Epi Data Briefs.
Got it, okay. Perfect. And then similarly, same question with dementia, cognitive decline, and co-occurring mental health conditions. How have those rates, do you know what the most recent numbers or how those rates have changed since COVID in 2019?
Right, so from a national aspect, let me just give you that first and then compare it to us. So estimated 6.7 million older adults with dementia, in this particular case, Alzheimer's disease. Alzheimer's dementia is the most common type of dementia, accounting for 60 to 80% in the United States. As Chair Hudson mentioned earlier, and I appreciate your opening statement, Chair, I also have a personal stake in it. My mom, who will be 90 in October, diagnosed with vascular dementia. So not only am I a clinician, that deals with geriatric psychology, although that's not my area of expertise, my siblings being caregivers and my sister having the brunt of that now that we all live out of town, really is looking at how that information can be used to support caregivers. And so when you think about the particular data that you mentioned, Chair, for New Yorkers, it's actually not as prevalent as the rest of the country. So it's a little less than the national average, but it's still prevalent.
Is that because people are not getting tested and diagnosed? Yeah. What's the reason?
I think I can't give you a clinical answer, but I can give you a more anecdotal answer if that's okay. And that is one thing. As an example, my mom is in Ohio, rural Ohio. Not as many opportunities to be in communion. Social isolation is higher. New York, being dense, actually has better outcomes for adults in terms of older adults in that way, in that there is more accessibility and more peers in terms of that. But in terms of whether they're getting tested and whether there is a specific test that some are getting and not getting, I really can't speak to that, Chair.
Yeah, because I know you have to go through a neurological process, which I think is more cumbersome, I would say. So I could see how that could potentially deter people from going through that process, especially if there's not a doctor or physician that they feel understands where their cultural needs are or language needs, maybe, perhaps.
Yeah. And we have a unit that's, in Checkwell, which is our Center for Healthy Equity. And I'm just looking at some of they don't have specific numbers for testing or how many people get tested, so that's why I'm kind of hesitating on giving you a definitive answer. We don't have a definitive answer on testing.
I do know that if you're Black or Hispanic, your rate of, or at least Alzheimer's disease is more prevalent in those communities, and also for women. So,
Yes.
I don't know population-wise compared to the rest of the country where New York stands, but
Yeah.
I'm surprised to hear that statistic.
Me too, especially on the depression and the suicide also, because I know that studies have shown, I think a lot of the Asian older adult women have some of the highest rates of suicide and depression. So I'm just wondering if that's it may just be, I don't know in terms of number-wise, but maybe percentage population comparatively, but interesting. Okay.
Right, and Chair Hudson hit on an important point, and that is the inequities based on race, ethnicity. And so there's certainly the numbers are a lot worse for that particular group. Black and Latino New Yorkers is definitely more pervasive.
And when you're collecting the data, is it mostly from, where is it coming from? Is it mostly just hospitals, individual physicians' offices, nonprofit organizations? Like, where is the data being collected from?
So the data is being collected from the areas that we support. So we have over 200 providers, but we also partner with H&H hospitals. We also partner with our CBOs. And so it would be a combination of all those accessible points that have data on the folks that we can actually connect with in New York.
Okay, good to know. Okay, and then just really quickly, this is more for, I think, DOHMH, but also hopefully DFDA, but how do you guys also partner with the state folks on the mental health piece?
Yes, we do partner with the state. The state actually has a little more robust budget, as you can imagine, in that regard, but we certainly do partner with them with many of our programs.
Okay, the reason why I'm saying that is because maybe you guys can join me, but I'm like really, really, really trying to plead with state Department of Health, specifically their Medicaid department, because, and I think the OMH Commissioner, Ann Sullivan, is really great too on this, and she gets it, because we're trying to see, it's not just about how do we sustain the services that are happening in the city with a lot of our providers in the nonprofit community. So how do we not just reimburse higher for this current services, but also how do we cast the net wider to get more reimbursements for things like education and outreach services, because I would argue that those are just as important. So I don't know, maybe you guys can join me in that sort of advocacy, because I would love to see that being both wider and deeper in terms of what we can do, because that's more of like a state issue. I understand it's not really something the city can change, but I would love to see if there's more we could do there and partner on. Yeah.
We appreciate your support in that regard, Chair.
Happy to partner as well. Obviously, We know there's some shifting landscape at play right now. While we were granted the authority for 1115 waiver, Department of Social Services and others are really taking the lead there. We agree with community care and all the other things that affect, but I think we're happy to partner, but also know that there's some shifting sands right now.
Okay, sorry, I'm going to toss it back to you. Okay.
No problem. Before I continue on with my questions, I want to turn it over to Councilmember Mealy.
Good afternoon. I just have a few questions in regards to community care. If we have the programs in the centers, what would your clinician consider someone mentally, and they would refer them for the services? If someone come in a senior center with 10 bags and an umbrella up, how would the clinician approach that individual, that senior, to even try to get them resources that they need? Could you give me an example?
Sure. So I don't want to go too far down with this case because
That's a rabbit hole we don't wanna
I am not assessing the individual. I'm not their
None.
clinical provider. The first thing I would say, though, again, you've been to many of our centers, council member, and I can think of 3 or 4 where I've met someone with their bags and umbrellas and so on, including in the last 2 months.
Same here.
I'll give you that example where the staff, so put clinicians aside, although the center director was a licensed clinical social worker herself, she wasn't part of the DJMH program, but they did have a DJMH program at that site also. The first and foremost, some compassion and engagement, not making assumptions about what's going
Never.
on with all the bags and the umbrellas, right? Like, we gotta make sure that we remain welcoming to everybody, and try to understand what's going on with that individual. It so happened that that center director knew that individual really well, and there were things at play. The person was in care. They were in psychiatric care, and that day and many days, not all days, they were engaged as much as possible with their other center participants, right? So engagement, trying to engage the person compassionately and understand what's going on. This is independent of the DJMH program, is something we expect of all centers. And then I think, given that person was in care, if there was a need for ongoing counseling or other kinds of engagement, then I think the center director would be working closely with the DJMH clinician on site to.
How often do you think they come together and talk about those kind of issues with our seniors, that they will be still treated with dignity, and how you could delicately make sure that their resources is given to them in a proper manner, respectfully? How often do you think that each center talk in regards to how they would address situations like that?
I can't give you a number on this record. What I will
Do you
tell
think
you is
we should? Because it's happening.
Let me answer
Some
the
of
first
our
part of the question,
seniors
Councilmember.
are displaced, and that's gotten them mentally unstable just
Sure.
as well. Some is homeless.
Yep.
So how can we get a group that address those issues right there with the clinician?
Yeah. So again, council member, part of what I was trying to respond to in your questioning was specifically about the center director period and the staffing on site, right? I'm sure the chair of the health, having run centers, understands case conferencing and making sure you know your members is a bottom line. As I shared earlier in a response to a question from, I think, Chair Hudson, we at NYC Aging have been looking at our assessment process, and actually one of the things when we surveyed our older adult center directors that came up was precisely what you're talking about. So while they might be dealing very carefully with that on a site-by-site basis, there is more to be done here. There's some programs that are great at engaging. I think of, I don't want to name names, but there's some programs who might have more individuals that are homeless or unhoused than others, and are spending a lot of time sharing best practices within the network. But to your question about how often, I think they're required to have these conversations about their members,
They having
frequently.
conversations, but
Yep.
what are they really trying to hone in on to
Yeah.
make sure that our seniors
Let me be
addressed?
concrete with you then. Case assistance, and ensure that the individuals are
Do you have
connected.
any database on the case system?
Yeah, of course I do.
I would love to see that.
I'm happy to provide you with numbers around case assistance. I'm also happy to invite you to conversations where you have providers who are more apt at this. And one of the things that we plan to do, as I shared earlier, is make sure that we do updated trainings for all of our older adult centers.
I love it. I will definitely meet with you.
Okay.
Can I have one extra question? You said the RFP. How soon would you feel a RFP will be given? I read in one of the statements. How long is the process for RFP for a program?
Are you referring to the RFP process for the DGMH program or generally?
Generally, and both, really.
Well, you previously chaired the contracts committee, so you know that a request for proposal process could be rapid or it could take some time. Now, in terms of if you're asking about DGMH, we're in the middle of our programs right now, so there isn't an RFP that's planned for tomorrow. As an example,
What about a senior center?
If you're asking about the older adult centers, the answer is still the same from budget as well as prior, which is we were looking at whether or not we should be releasing an RFP this year. You've heard that message before.
Well, the commissioner said that it would be happening.
I think you can refer to her testimony in the last hearing. She also said that that is our plan. We're gonna have to look carefully, especially with the current contacts, federal government and otherwise, at whether or not it is prudent to release the RFP right now, i.e. the end of this year. Our plan remains, we will continue planning as if so, but we're
Okay.
gonna be looking at whether or not the release timeline is prudent. And I think
Well,
she said that in different words
Okay.
at the last hearing.
I was just trying to make sure I'm hearing everything correctly.
It's consistent messaging.
But please know that right now, we need a RFP in Brooklyn with Mount Ararat. Right now, it is on a city dime, so I'm looking forward to making sure that a senior center, a senior house in 420 units, need a center, a certified RFP center. So please keep that Mount Ararat.
Okay. Thank you for that. You've raised Mount Ararat many times. I'm glad
Thank you very
that
much.
Fort Greene is in there with you
Yes.
and operating that center currently. And thank you for the funding to make that happen.
Thank you. I would love to talk to you afterwards.
Okay.
Thank you,
Thank you.
council member. Okay, how many DIFTA clinicians or partner providers speak a language other than English? I know we talked extensively about the presence of the services, but do we have a number?
I can get that back to you on that number.
Great. And the languages that you mentioned before are the languages that you provide services in, but are those also the same as the languages that are most in demand? And I guess a better question would be, is there a gap between the languages that you're providing services in and other languages that are being requested at sites?
Sure. I think we'd have to look at that really carefully, right? But these are the in-demand languages across our network. There are obviously emerging languages.
We're good.
But I would have to get back to you on it whether or not there's gaps. But this is a pretty broad swath of languages for New York.
Yeah, definitely. And I would just be curious to know, and you can follow up with this if you don't have it now, but at those 88 sites, like how many people? Is it, one per every 3 or 4, or like across those different languages? Those are the types of numbers I would like to know.
Understood.
What strategies are in place to address stigma around mental health services among older New Yorkers, among immigrant communities specifically, and communities of color? We've all sort of touched on this a little bit, but I'm wondering if there's sort of deliberate programming or information being provided, approaches being taken to address the stigma?
I think, as I shared earlier, the way the program is structured itself is in response to stigma in terms of structured and unstructured engagements, presence of a clinician, ensuring that the clinicians are of the community, have the background, have the language capacity. That in itself ensures that the presence, and this is a routine. You know Judy, who comes here every Tuesday and Thursday. That is deliberate. It might, not to you, it might sound like it's just a thing, but it's actually deliberate so that that clinician becomes a part of that older adult center. That is what the model is based on.
That's great. It doesn't sound like just a little thing. I just,
Not
want to
you,
make sure I'm getting the information on the record.
Okay.
But I think, it's a great example that is exactly how we lift the stigma, and how somebody would then feel like it's no big deal to go see Judy or talk to Judy because Judy's always there. So I'm with you.
And Chair, I mean, the other thing is, I know we're saying better off outcomes, and I love that. We'll keep looking at prevalence data. The reality is that we know that folks are either late onset of mental health, underdiagnosed, misdiagnosed, untreated. Those are all things, right?
Mm-hmm.
That are facts, and that could be showing up in whether it's the prevalence data or other places. We will soon be sharing with you a little more about the needs assessment survey from last summer, and comparing that to other reports that are out there. Some things that struck me, 53% in from whichever report I was reading the other day, and I'll find you the source, of folks older adults don't actually seek support. That's it. That in itself sets up this conversation for making sure that we're where people are. And then part two, folks are only going to loved ones, right? And so accessing other care networks and other resources are automatically a place where we're going to find some challenges. So this is why, thank you, Doc, for sharing your personal story earlier. It's so important that we spend time with caregivers. You've heard Commissioner talk about caregiving before, and all of us, right? Like today is actually the birthday of one of my aunts who passed away recently and had rapid cognitive decline in her last few months with us. And so preparing caregivers, and the caregiver in her life was my other aunt, who's a bonus mom, and she's 80. Well, I don't know if she wants me telling her age, but I'll do it anyway. She's 83, and her sister was 86. And so it's really important as we talk about mental health and who and where we are. It's not just in our centers. It's making sure that we're everywhere, especially for caregivers. And I don't need to tell you that, but it's really important for everyone here. That is a place where we need to go also to reduce stigma.
Absolutely. And since we're on the topic, and Councilmember Amelia brought this up as well, I do want to just ask, one of the fastest growing populations is homeless older adults. And so I'm wondering too if there's, because I'd imagine there has to be some sort of overlap perhaps with mental health diagnoses and people who might be newly experiencing homelessness. And so I'm just wondering if there are specific efforts to address that in some of the clinics, in some of these older adult centers, how people are being connected to resources and services in that way too, from like a preventive perspective.
You want to go first?
Yeah, I'll start and then jump in. So I think it's important what you're saying in terms of several things. One is the stigma. And so having workshops and focus groups is one area that when we talk about the disparities as an example. So we've had over 54 workshops and over 6 focus groups for 50 years old and older for Black participants specifically in terms of how they understand the information that is being given out there. And so some of the information we've received in terms of key insights, current communications. Are we communicating in a way that a person can actually receive the information? Think about it. If it's just on the website, that's going to exclude some folks, right? If it's just being handed out in a pamphlet, that's going to exclude some folks. So we really need to understand how people receive information. So that's the kind of feedback that you get when you have focus groups. I think also looking at stigma, denial, and shame, and looking at the lack of awareness are key barriers. But you also have to understand is who's having the conversation. Are they credible messengers, as an example? You know, we talked about peers earlier, and so that's very, very important. When you think about where individuals are going to get this information, going to some of these mental health clinics, Chair Lee's favorite, clubhouses, right? That's, you know, a lot of the individuals are 55 and older that, you know, but they're with serious mental illness. 55% of the folks that are in our supportive housing are seniors. And so that's a resource in terms of how to get connected. When you think about all those things, it's a multi-pronged approach in terms of, one, how do we communicate? How do we get the information to individuals? What are the things we're hearing and that we can implement immediately? And then how do we meet people where they are so that we can't just talk about stigma, we also have to talk about inclusion. And I think you can't have one conversation without the other.
Thank you.
Covered it. The other thing I would say is that, frankly, our provider network is so critically important here. You know, we don't just have older adult center operators. These are nonprofits who are embedded in community and multi-service often, or have really strong ties. I'm already thinking about like folks at Encore, Project Find, you know, others that run supportive housing operators who also have older adult centers, right? It's important to make sure that we continue to support the nonprofits in this case, who are there and are the front lines of responding to all these needs, right? And, you know, Department of Social Services isn't here today, but we spent a lot of time making sure that whether it is with their supportive housing or adult protective service and others, they're at the front lines of this in terms of outreach. Folks have aged in place on the streets, are known to the providers in the community who are doing outreach, and have moved people more quickly into supportive housing in the past few years. So, spot on. More to be done.
That's good to know. Thank you. Are DFDA's mental health programs reaching LGBTQIA plus older New Yorkers? And do you have any data on those aging alone or disconnected from traditional family support?
We could follow up on that specifically in terms of data, but yes, we are reaching LGBT community members, and you know, we have programs that are run by LGBT community organizations as well. Thinking about SAGE as one example for that, it has a both older adult center and caregiver. They are not operating a DGMH program, but our operators will work closely with many of the program providers. So yes is the short answer. For data, because it's an intricate question, I'll be happy to follow up.
Okay, sounds good. Thank you. How have the fiscal year, I'm going to go into budget and contracts for a second, okay?
Okay.
Or for a few minutes, rather. How have the fiscal year 2024 and 2025 PEGs impacted funding for DFDA's mental health services, particularly for staff contracts and outreach initiatives?
They haven't.
Okay. At all?
No.
Okay. How long did it take to implement the most recent RFP for expanded DGMH services?
Do you mean how long it took to develop the RFP itself?
No. To award it?
What I'll say is, trying to get the spirit of the question. The pilot was 2016, as we shared before, and we've expanded the program twice. And the expansion that was, so if you are doing the math from 2016 to 2022, that's one timeline. But in terms of the RFP development process, I'm happy to come back to you on like actual timelines from that, when it was released to when the provider was selected to when they started. If that you want to talk concrete procurement timelines, I'm happy to figure that out.
Okay, that would be great. Thank you.
Kind of gets a little bit to Councilmember Mealy's kind of question. How long does it take to do an RFP?
Yeah.
Right?
What additional investments are needed to scale services like PACS HB and Teleprotect to meet the demand among homebound older adults?
I think I hinted at this earlier. telehealth itself is the thing that we need to spend time on, right? And it is available today in our programs in terms of folks who might be homebound, and there's much more that we can do there. I think there have been a number of models in the world, Protect being one, and we're actively trying to look at what are those emerging models that are best suited, and how do we increase our capacity. I think while there are many specialist organizations out there right now, some are here, some are probably watching at home. One thing that's important to this, to the commissioner and me, is making sure that we are deepening our bench, and that you were asking questions earlier, council member, about the folks in centers, right? It is so important that while even if there aren't clinicians in centers, peers or otherwise, the people who are operating have that capacity to engage compassionately, know where the resources are. That's why we spend time training. So there, I would say what's important is actual training. It's actually deepening the models and documenting. That's what's important for those models.
Thank you. And what's the plan for sustaining DOJ or OMH-funded mental health pilot programs when grant funding ends?
Well, like with most, we will. The world of grants is different, Chair. And
That's why I'm asking the question.
I know. Look, I think we have. We're pleased with new developments like the JFNA funding, right? That's a foundation. And so we are continuing to, our development team with our program team, look for opportunities out there where we can, shift what we're doing. And thank you for the reminder. We have a new program called Boost, which again, we're looking for other models, right? That will be supporting older adults, whether it's telehealth or survivors of violence and abuse. We continue to do development work on our side. Where we can integrate clients with the existing core DGMH programs, we're also doing that.
Thank you. How does DIFTA evaluate the effectiveness of its mental health programs?
I shared some stats with you before in terms of, looking 3 months after, the initial clinical sessions begin. And as you heard, from 20% to 60% thereabouts improvements in various metrics. That's the kind of research that we're doing, impact research we're doing internally. You should also know that we had recently a pitch fest that we participated in, which was like looking for research partners. So thank you to, if any of you are here, there are like 8 researchers who are interested in partnering with us to evaluate some of the impact of our programs. And one of them is on the impact of older adult center programming on cognitive well-being of older adults, right? Like not just mental health programs, but all programs. And the other one is implementing STEAM, like science, technology, engineering, arts and math programming. So we are actively, I know we respond to some of the university partnerships, but we're actively looking to deepen what we know, understand, and are able to do. And older adults in community are asking for it as well.
Thank you. Do you collect client feedback for each of your mental health initiatives?
I'm seeing a nod here that says not for each, but I can tell you some of the, probably get back to you with
The nod
some
I
of,
saw was a no.
but go ahead.
That's
not not for each.
Okay.
I knew what that meant. We do get feedback.
As agencies speak over there.
Yeah. Not for I'm responding to your question.
Yeah.
Not for each, based on I think how that's structured with the clinician and so on. But we are evaluating the programs, and in some of our areas. So we didn't spend much time talking about our elder justice programs. We are often surveying and getting feedback from clients as they have benefited from our services. So not for each program, for a variety of reasons, but that is our practice and our goal.
Okay, thank you. And what are the 3 greatest unmet mental health needs of older New Yorkers according to providers?
That is a. You want me to rank right now, huh? Here's what I will say. I will join Doctor in acknowledging that we need to continuously invest in staff. That's documented well throughout. Build those partnerships from social work schools and other settings to ensure that we have capacity within our networks to provide services and pay folks well. Right? That's part of what we need to do. In terms of mental health needs, I think the stigma piece, again, well documented. Folks are not thinking, let me go get my mental health checkup. Maybe folks are going to the dentist twice, not once. Absolutely, folks are going for their annual checkups. So I think routinizing mental health care and wellness is also a major top three.
Yeah.
And then I think the third is screening. Once we get past this is a part of it, like really, what do I do when and if I feel, or what if the doctor or if the clinician tells me? And I think that's why the DGMH program continues to be important, because it provides on-site, in-community access and navigation support to individuals so that they can actually get care.
Thank you. I want to ask a couple of questions about my bill, which would require the Cabinet for Older New Yorkers to study and report on the provision of agency services to older adults with certain neurological and mental health conditions. Does the city currently track older adults with neurological or mental health conditions across city agencies? So, like, you know, if somebody is interfacing with HRA as an example, and somebody in HRA somewhere is like, you know what, this person might have Alzheimer's disease, are they then sharing at least, we've had 10 people that have come through our agency with DOHMH to say, or even NYC Aging to say, hey, just FYI, or maybe you want to know, or maybe you have programs or services or resources that might be relevant to this person who we've already interacted with?
So, Chair, I can't speak to that level of detail in terms of the communication between agencies, but I can certainly find out what communication is occurring. In terms of tracking neurological data, we do have our unit of health equity that I mentioned earlier. They mainly focus on dementias specifically. Mm-hmm. And so it's a fairly new unit, and so I can certainly get back to you in any detail in that regard. But in terms of internal cross-system amongst other city agencies, I can't speak to that today.
Mm-hmm. Yeah, and that's fair. I think generally we could probably all agree that there isn't enough interagency discussion, coordination, collaboration, and this is probably across all government entities, not just here in New York City. So just, want to note that for all of us. How would DOHMH work to identify the top 10 neurological and mental health conditions affecting older adults, and what might the anticipated timeline for something like that be?
I can't speak to the timeline, but what I would say is the way we gather other information is through epi briefs and surveys. Community surveys, also talking to our providers, would be a way to gather that information. Do not have a specific timeline that I can give you today.
Okay. And what criteria would DOHMH use to determine the most common conditions? For example, incidence, prevalence, impact on service use, or another metric?
Repeat the question. I'm sorry, Chair.
What criteria would DOHMH use to determine the most common conditions? For example, incidence, like rate of incidence, prevalence, the impact on service use, or
Gotcha.
Perhaps another metric.
Understood. And so, again, by using the epi data briefs and the surveillance that we do, we would be able to rank them in that regard.
Okay. One other just sort of anecdotal piece that I'd like to offer is, in my office, we've been contacted by a number of constituents who have neighbors. They're calling essentially on behalf of their neighbors. And usually the story goes, I have a neighbor, Miss Jones. She's lived next door to me or across the street from me for the last 20, 30 years. she's now, in the hallways late at night or outside. She's ringing my bell late at night. She's making these claims that don't seem to make sense. Things like that. Or maybe she's walking down the street, in her nightgown, which I've never seen her do before. For me, because I have personal experience with Alzheimer's disease and the early stages and how it can present, I usually think, well, maybe this person has some form of dementia. We've also had cases where the police department has been involved in folks making these sort of very elaborate claims about their neighbors, and come to find out when you do a little bit more digging, they do have dementia. But because they're socially isolated, because they may not have any next of kin, and because their neighbors and even the NYPD may not be familiar with these types of symptoms, then they're obviously not really getting the type of help they need. I mean, we've gone to doctor's appointments with people before just because they have nobody to sort of advocate or even confirm or get the information, so that we can then help them get access to the types of resources that they may be qualified for. So I just wanted to share that because I think there's so many opportunities for us to be doing a lot more in terms of how we're supporting every New Yorker who might be experiencing something like this, that doesn't have the support systems, who may not be going to older adult centers or drop-in clinics or anything like that. And so just thinking about how do we actually get the word out? How do we share information? I have legislation trying to make the NYPD, get training on how to spot Alzheimer's and dementia and things like that. But I don't know if you have any thoughts or anything to share, but it would be, really great for us to all sort of think together and collaboratively about how do we, especially with the growing older adult population, and assuming that these types of diseases might become more prevalent, how do we actually address some of the folks with these?
So first and foremost, thank you for that sharing. I would start with 988, right? And so we need to do much, much more in terms of, when I say us as a collective, as a city, to make sure that people understand that 988 could be for someone who just needs someone to talk to, all the way through, having some major challenges, all the way to being suicidal. That the continuum is that great, and so the vast majority could be helped by calling 988. There's going to be a clinician readily available to talk to them on the phone, and if necessary, a mobile team, a crisis mobile team, will be deployed, and then that team will then assess the individual, and they would be experts clinically to find out what we're really dealing with. Your average neighbor probably doesn't know that, as you just pointed out. And so if you're not sure about 911 or 988, call 988 and let us assist you in that way. That's probably not the time to call police, because you're not paying attention to seeing any public safety issue, as an example. Right. 9 times out of 10, people who make calls are calling about something they've observed, a person, family member, as you put it, neighbor. They're not usually calling about themselves necessarily. So that's another reason that if you're observing something, to call 988 first, and then let those professionals take it from there, and then get you connected as whatever is needed. They know what to do.
Thank you for that.
I think it's also important to go back to why the cabinet exists, right, Chair, which is to strengthen information sharing at all access points. And so 988, absolutely. Some folks are going to continue to call 911, and the precinct is going to show up, and that's why it was important for us to establish a liaison, older adult liaison in every precinct, right? And so now I can say that nearly 40,000 members of service and civilians have been trained. However, boosters are needed, right? And there's always going to be more to be done here. And I think maybe we could consider looking at what a partnership looks like to zero in on some of these issues that are showing up in community. We literally had a call a couple weeks ago, this kind of exact call where we got the person who oversees all the older adult liaisons on the phone. They got the liaison to go down with some people from the precinct, and APS got involved because there was a hoarding situation and a few other things going on, and that person got a pathway to care, but they've received multiple calls up until that point. It just happened to finally get to the right structure. And so we need to strengthen our access points, whether it's the hospitals or it's the police department or anywhere else, so that we're all speaking the same language. And you said it earlier around geriatrics, right? We need to make sure we deepen that practice. So I think we could spend more time evolving the training that everyone's taken, so that they're better positioned to act.
Thank you. I'm going to throw it back over to Chair Lee for some additional questions. Thank you.
Sorry, just one last bucket around the substance use and opioids. The reports have shown that substance use, especially those 65 and older, has increased in recent years. And can you just speak to whether those rates have changed since the pandemic, and if so, how?
Thank you for your question, Chair Lee. Before I answer that question, let me give you the answer to your question you had asked earlier about depression. And so it did increase slightly from the 9% that was quoted earlier.
Okay.
But it's at 12% for older adults, which is still slightly lower than the rest of New Yorkers, which was 13%. So you were correct. It was slightly elevated, but only at 12% compared to 9%, and compared to the rest of New York, which was 13%.
Okay.
In terms of your question specific to overdose, and so as you probably remember from our previous hearing, although the rates of overdose had declined very slightly for all of New York, for Black and brown New Yorkers, it has increased. And so in specific geographic areas, we're talking in terms of the Bronx, in East Harlem and other areas that I'm blanking on right now. But in terms of the comparison to previous, you said the pandemic, yes, they have increased quite a bit. And so that is a major concern for us at the health department. And so we certainly are taking that information very seriously and working with our partners across the city to make sure, one, we address those exactly in the vulnerable communities that it exists, but also talking to our community providers to make sure that we have an understanding that what are we doing to address those issues. And so we're taking it very seriously.
Okay, perfect. Given the rise in substance-related mortality among older New Yorkers, does DOHMH differentiate and report on substance misuse patterns, like using prescription opioids versus illicit opioids for the older adult population?
We do, and
Okay.
that's part of the surveillance data that is gathered and
Okay.
published.
And maybe this is more anecdotal from your perspective, and there isn't any clear data, but I'm just curious to know, are the older adults who are engaged in substance use, are they because they're people who are aging that have been using, or are we seeing a more prevalence of older adults that are maybe new users?
If I'm understanding your question, I would say I cannot speak to whether they are new users or not. What I can say is that we are tracking the type of substance, and generally individuals have a history of substance use for a period of time.
Okay. Thank you.
And just lastly, does DOHMH work with or consult with citywide harm reduction programs to ensure integration of age-appropriate screenings and referrals for older adults who suffer from addiction?
We do.
Okay. So groups like On Point and others, so you coordinate with them?
Absolutely.
Okay, perfect. Thank you.
Okay, sorry. And then I just had one last question about the legislation. If the Cabinet for Older New Yorkers is not the ideal forum for developing the report required by Intro 1257, as you state in your testimony, Executive Deputy Commissioner, how would you ensure through this legislation that all relevant agencies weigh in on how to improve the provision of services to older adults with neurological and mental health conditions?
I would say that is part, thinking of the cabinet as action oriented and looking at sustainability. I would imagine that what we would do here is with the health department, H&H, Office of Community Mental Health, and others who are always active in the cabinet, that we prioritize these conversations. As I mentioned earlier, the agencies are the ones who do the work. So the cabinet itself doesn't just issue reports. Like, we have our needs assessment data that's coming out, and through the BOLD Coalition, there's work that's going to be done as a part of strategic planning. And so those are already reports that should be available. I would think that through the cabinet, one of the things that we commit to, as we always do, is thinking about the initiatives that go into this, right? Like what we would actually do, whether it's I don't know. We talked about training for a little bit just now, and making sure that all frontline staff. So we already have one of those initiatives, but maybe there's a focus in terms of content, a new module, something in person, some commissioners rounds, maybe bring some experts to the table. I think that's the kind of thing that the cabinet does, and that we'd be more than happy to advance.
Thank you so much. Thank you both for your testimonies and for answering all of our questions. I'm going to move on to public testimony. So thank you. We appreciate your time. Okay. All right, I now open the hearing for public testimony. I want to remind members of the public that this is a government proceeding and that decorum shall be observed at all times. As such, members of the public shall remain silent at all times. The witness table is reserved for people who wish to testify. No video recording or photography is allowed from the witness table. Further, members of the public may not present audio or video recordings as testimony, but may submit transcripts of such recordings to the Sergeant-at-Arms for inclusion in the hearing record. If you wish to speak at today's hearing, please fill out an appearance card with the Sergeant-at-Arms and wait to be recognized. When recognized, you will have 2 minutes to speak on the oversight topic, mental health in older New Yorkers, or on Introduction 1257, Proposed Resolution 106A, Resolution 736, or Resolution 852. If you have a written statement or additional written testimony you wish to submit for the record, please provide a copy of that testimony to the Sergeant-at-Arms. You may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. And I will start momentarily with, okay, panel one. Jordana Weber, thank you. Kumari Cruz, Fiona O'Grady, and Anita Kwok.
Good afternoon. I am Jordana Weber, Chief Program Officer of Service Program for Older People, or SPOP. Thank you, Chairs Hudson and Lee, for holding this oversight hearing on the subject of mental health in older New Yorkers. I'm grateful for this opportunity to address the two committees today. SPOP plays a unique role in supporting the health and emotional well-being and independence of older adults, and has done so for more than 45 years. We are the only agency in the city that is exclusively dedicated to community-based mental health care for older adults. We provide outpatient treatment to over 1,000 people each year through individual and group therapy, assessments, medication management, and psychiatric rehabilitation. We understand that older adults may face multiple barriers to mental health care, and we've developed strategic partnerships with older adult centers, hospitals, and other community-based organizations that connect us to those who might otherwise have no access. We have also built a network of 20 service locations and satellites, 7 of which are DGMH sites, in Manhattan, Brooklyn, and the Bronx, where clients can receive mental health care at the same place they receive aging support services. Chair Hudson, to an earlier question, SPOP also has 3 LGBT-specific sites. We were especially proud when NYC Aging adopted SPOP's co-location treatment model to integrate mental health care into older adult centers. Education is central to our mission, and we share our expertise with other organizations and professionals that work with older adults. We teach the ins and outs of Medicare billing, which ultimately expands the provider pool. In other cases, we provide workforce training on such topics as older adult substance use, trauma, or suicidality. And Chair Lee, to one of your earlier questions, SPOP also is in year 2 of a social work career pathway, bringing MSW interns into the older adult mental health orbit. Perhaps our most important role, however, is advocating on behalf of older adults with mental health needs. Our goal is to increase access to treatment throughout the city, and we believe that older New Yorkers deserve to have the entire city on their side. But while we love what we do, we can't be the only ones doing it. I'm here today to express SPOP's enthusiastic support for introduction number 1257, which focuses on the identification of the leading neurological and mental health conditions affecting older adults. We believe that this bill will call attention to healthcare needs and impact decisions affecting policy and service delivery options. Clear data can inform a strategy to address those healthcare needs. Through our work, we have seen the despair that ensues when a person's needs increase as their financial resources dwindle, which only exacerbates their mental health or neurological condition. This bill recognizes the need for all city agencies to come together in order to support our most vulnerable New Yorkers, not just those that provide mental health and aging services, but across the sectors represented in the cabinet. We share the council's aims to make New York City a great place to grow old. If a city defines its worth by the way it treats older adults, then this bill may bring us closer to that goal. To that end, greater investments to support the mental health needs of older New Yorkers are critically needed in the budget. Thank you for your work on behalf of all older New Yorkers and for this opportunity to testify.
Thank you so much.
Thank you, Chairs Hudson and Lee, for convening today's joint hearing on older adults and mental health. My name is Anita Kwok, a policy analyst representing United Neighborhood Houses, a policy and advocacy organization representing New York settlement houses. Our members provide a wide variety of services to over 800,000 New Yorkers each year by operating programs in areas such as older adult and behavioral mental health services. Many older adults served by settlement houses are low-income immigrants with limited access to food, housing, healthcare, and mental health services. Language barriers and mental health stigma further prevent them from seeking support. Settlement house staff are essential to the community, assisting older adults in navigating complex welfare systems, such as benefits, enrollment, and access to care. UNH is a longtime supporter of the Council's Older Adult Mental Health Initiative. It makes mental health services accessible by putting them in community spaces where older adults already gather, such as senior centers, NORCs, and food pantries. It increases the capacity of CBOs serving older adults in identifying mental health needs, providing immediate mental health interventions, and referring clients to further psychiatric treatment when necessary. With recipients of this funding observing rising levels of social isolation, bereavement, and fear among immigrant populations, CBOs are able to meet their clients where they're at, which are often in non-clinical settings like churches, which Chair Lee mentioned during questioning. Given the vast success of this program, we urge the Council to restore full funding to the Older Adults Mental Health Initiative of $3.5 million in FY26, which includes a 3% COLA to match the citywide Human Services COLA. Our members have also observed an increase in fear among older adult immigrant populations because of the anti-immigrant rhetoric and policies by the new federal administration. Furthermore, unpredictable federal policy proposals have placed additional strain on aging services providers. Earlier this year, a proposed elimination of social service security phone services would have forced millions of older adults to seek in-person help, even as staffing was being cut. Settlement house staff scrambled to prepare for a surge in client needs. And although this policy was rescinded, ongoing SSA staff cuts and frequent website outages continue to make accessing services difficult, compounding the burden on frontline providers. UNH urges the Council to pass Councilmember Shekhar Krishnan's Resolution 852, calling on the U.S. Congress and the President to take steps to protect Social Security. Thank you for your time.
Thank you so much. Thank you both for your testimonies.
Thank you.
Okay, I'll call the next panel: Chelsea Rose, Janine Cahill-Jackson, Navdeep Bains, and Emma Basire. Anyone can begin, and then we'll just go down the line.
Hi, and thank you for the opportunity to testify today on the topic of mental health in older adults, and to the chairs for holding this important hearing. My name is Emma Basir, and I am the Senior Associate of Policy and Advocacy representing City Meals on Wheels. The issue of mental health is of particular importance for City Meals due to the heightened rates of social isolation that older adults who are homebound experience and the consequences of that. Numerous studies have found a link between being homebound and not just social isolation, but depression and a broad range of medical and psychological conditions, as Chair Lee mentioned earlier in this hearing. In a recent study of over 500 older New Yorkers participating in congregate and home-delivered meal programs, we learned that not only half were experiencing food insecurity, but more than 50% lived alone. We also learned about their mental health concerns and their access to support, such as that 38% of participants reported that loneliness and depression were problems for them. And yet, a staggering 82% never accessed mental health services. 45% reported having little to no support from family, friends, or a personal care attendant for meals, which suggests that they may not have that same support for other types of needs that they have. A majority also live on $15,000 a year or less annually, and 25% reported not knowing about general support services available to them. These data suggest that not only is there a need for programs that address depression, loneliness, and other psychological conditions among older adults, especially those who are homebound, but that there's also a gap in existing supports and access to them. We urge the Council to restore full funding to the Geriatric Mental Health Initiative at $3.5 million in FY26. The initiative provides critical screenings, referrals, counseling, and more, and it's vital to meeting older adults where they're most comfortable and fulfilling their mental health needs. The virtual and telephonic options are particularly critical for homebound older adults who may not regularly attend an OAC or have access to in-person mental health services, but can be referred through their case manager. A further investment at $800 million is also needed in order to address critical infrastructure issues at older adult centers across the city. Older adults deserve to access mental health services in centers that are accessible and in good repair. And we thank the Council for their efforts to support the mental health of older adults through this hearing and urge you to adequately fund the programs older adults so desperately need.
Thank you so much.
Okay. Thank you, Chair Crystal Hudson and the Committee on Aging, as well as Chair Linda Lee and the Committee on Mental Health, Disabilities, and Addiction for holding this hearing and for giving us the opportunity to testify about the mental health needs of older New Yorkers. I'm Navdeep Bains, Associate Director of Advocacy and Policy at the Asian American Federation, where we proudly represent the collective voice of more than 70 member nonprofit organizations serving 1.5 million Asian New Yorkers. As the Asian community faces a challenging landscape due to federal funding cuts and anti-immigration policies, our older adults are placed at the center of this issue, with the intersection of race and age rendering them particularly vulnerable. While our member organizations on the ground continue providing high-quality mental health care, this increased demand, coupled with challenges obtaining and retaining culturally and linguistically competent staff, has resulted in increased strain on our CBOs. Without these essential nonprofit organizations and their life-saving direct services, our older adults would experience increased adverse mental health outcomes. Asian older adults are the fastest growing older adult community citywide, making up 14% of New York City's senior population, and this population growth has been coupled with an increase in poverty. Currently, 42% of Asian seniors are low income, and moreover, 25% of Asian seniors experiencing poverty live alone, and 84% have limited English language proficiency. This results in a high likelihood that they would experience isolation and loneliness, and these are key issues that our CBOs on the ground address daily with the support of City Council for sure. The topic of today's hearing is particularly important to AAF as we convene the Seniors Working Group and a Mental Health Roundtable. They're both working groups that we get together with our CBOs doing this work on the ground, and they represent the voice of 12 or over a dozen different CBOs serving over a dozen different Asian ethnicities in the community. So we're in support of City Council's measures discussed today, and we've been longtime supporters of Chair Crystal Hudson's age-in-place legislative package, including the proposed local law that was discussed today. We also support Resolution 106 because programs like this protect seniors from never-ending rent hikes in a time of economic crisis and threats to social safety net programs as well as Social Security. Expanding the eligibility of this program, which is the Disability Rent Increase Exemption Program, to include additional qualifying members will help seniors in the Asian community from facing immense hardship and stress, such as eviction and houselessness, and it would also help their family members that are also experiencing vulnerable situations. I just want to also mention that we are in support of Councilmember Krishnan's Resolution 852, because many members of the Asian community rely on Social Security to pay for basic necessities like groceries, utility bills, and housing. And for our older adults, this is the only source of income that they can rely on. And protecting Social Security will not only provide a steady source of income to our Asian seniors, but will also prevent worsening mental health crises from stress and anxiety. One of our member organizations that serves a community in Brooklyn says that Social Security cuts for seniors has been a major topic at their senior center and older adult center, and their attorneys in-house are doing workshops and trainings for the community because they're confused on what they qualify for and what might be cut and cause increased poverty. So just thank you so much to the council for supporting AAF's older adult initiative so we can continue to do advocacy, research, and programming work on this area, as well as our immigration rapid response work, which we're hoping to continue get support from and do well into the next year because the needs are continuing to grow. Thank you so much.
Absolutely. Thank you so much.
Good afternoon. My name is Chelsea Rose, and I serve as the Policy and Advocacy Manager at Care for the Homeless. I want to thank the committee members for the opportunity to testify today. CFH has over 40 years of experience delivering medical and behavioral health care exclusively to people experiencing homelessness in New York City. We operate 22 federally qualified health centers in shelters, drop-in centers, and soup kitchens, and we also run 5 shelters with on-site health services. Across our programs, our goal is to end homelessness by providing supportive services that help people move into stable housing. Today, I want to focus on a specific and growing population within New York City shelter system: older adults living with serious mental and cognitive disabilities and requiring a higher level of care than what is available in shelters. Facilities that could support them, such as adult homes, assisted living, and nursing homes, are frequently inaccessible. Many reject applicants with psychiatric diagnoses or don't have space. Even those who are clinically eligible can wait years for placement. In the meantime, too many aging and disabled New Yorkers remain in the shelter system, receiving fragmented and insufficient care. Residents at one of our shelters describe watching older women cycle endlessly between emergency rooms and shelters, struggling with basic daily activities like bathing, eating, and dressing. They have watched their mental health and physical health deteriorate in real time as they are living in a system that was not built for them. The following are some of their testimonials. Residents are acting as nurses for each other to keep them from going back into the hospital. Before entering the shelter system, I had a home aide that helped me bathe and take care of myself. Now I can't take showers because I can't bathe on my own. I go into the hospital like a revolving door, and then they send me right back here. These stories are not isolated. Without better pathways to long-term care, more aging New Yorkers will be trapped in systems that fail them. Without stability, without care, and without dignity, this is not only a policy failure, but a moral one. Thank you very much for your time and for your commitment to the health, safety, and dignity of all New Yorkers.
Thank you so much. Right on time.
Good afternoon, Chair Hudson and Chair Lee and members of the committee. I'm Janine Cahill-Jackson, Director of the Elder Law Unit with the Legal Aid Society, and I'm here today with many of my colleagues from the Bronx Neighborhood Office. Legal Aid is in support of all of the proposed bills and resolutions on the agenda today. But the one I wanted to focus in on my spoken testimony is the introduction of proposed bill 1257, 2005. This is a very important study. We first suggest that the cabinet should speak to legal services providers and other CBOs in addition to the other city agencies, because these folks work with seniors with neurological and mental health conditions on a daily basis and are very familiar with helping them try to access the city services that we might be, the cabinet might be seeking to find the issues with them being able to connect with. In our work, we encounter seniors with mental health conditions as well as cognitive decline, and they often struggle to access services. The one that really stands out the most to me is seniors with hoarding disorder. Adult Protective Services is the only organization that can help them with this, but the only service that's provided for these seniors is called a deep clean, which is a rather traumatic removal of all of their possessions. It's actually not in line with any trauma-informed or client-centered treatment. There's no supportive services, mental health services provided for the senior, nor any other alternatives such as decluttering, and the process is traumatic at worst and disempowering at best. In addition, folks with cognitive decline also struggle to access APS services. For example, they have to not only hear the knock on the door, understand to open it, and then be able to engage with the caseworker, but if they're not home at the time, the onus is put on them to connect through calling the caseworker by understanding the number on the business card. May I continue with just a few more points? Thank you. So this process is very hard for the seniors to understand and even to remember to do if they have short-term memory issues. Additionally, and I believe this came up earlier in the hearing, if the seniors experiencing Alzheimer's or dementia, they may not present as having cognitive decline, but in fact be demonstrating it through what they're sharing. So recently we had a client that was denied for Adult Protective Services a few times because he so clearly explained that every month he writes out a check and puts it in the landlord's drop box, and that he was able to go grocery shopping, etc. But in fact, he hadn't had food in the fridge for months and hadn't paid rent in over 5 years. But he wasn't aware he was not accurately reporting. And there was no further investigation. The case was closed after that initial assessment done in the apartment. On paper, it seems possibly it could be sufficient, but often a little bit more investigation is needed, perhaps verifying with collateral resources like family members or even the neighbors that you were referencing, just to help see, is this someone telling the story of them managing their affairs or explaining to you how they used to be able to and they don't know that they're no longer able to. So I will conclude with that last example. We will be providing written testimony to also address, there are a few issues with even accessing city PEPS renewals or accessing the process for Access-a-Ride. So we'll definitely be sure to include some client examples there in our written testimony. Thank you so much for your time today.
Thank you all so much for your testimonies. And just 1 second, I know Chair Lee has a question.
So actually, 2 questions for each of you. So for Chelsea, 22 FQHCs is no small feat. That's a lot of work, and I can just imagine how many people you have going in and out of the health centers. I was just wondering if you could speak more to, because I think the biggest frustration, or at least my biggest pet peeve, and I'm sure for Chair Hudson as well, is the silos that we have in government and how it's hard to move people through the system and throughout different services. So I just was curious to hear more about how you all are integrating the model, and if you could speak more to that in terms of how you're doing the FQHC clinics, and I know that it says you have the separate shelters, and so how are you sort of integrating the care for that?
Yeah, so we co-locate in the majority of those, of the 22 federally qualified health centers. Besides the 5 shelters that we run, it's partnerships with other organizations, and we do soup kitchens, drop-in centers, wherever people experiencing homelessness are already accessing. And then depending on the population we're serving there, for example, like assessment sites, or sites that are more focused on getting chronically street homeless individuals off the street, that care is going to be more short-term, getting them stabilized and integrated into the shelter system. Whereas at our shelters, we're able to provide more long-term care. Ultimately, the goal is to get them to regularly go to like primary care and dentistry and behavioral health appointments. But due to, cuts coming down from the federal government, and just generally in this sector, we struggle with staff retainment and maintaining these health centers and good quality care that, depending on the shelter and the number of staff we have on board, our health centers do struggle to maintain that the quality of care that I think many people, especially older adults in our shelter system, need. And ultimately, it's by their appointment base for many of these health centers. So for the individuals I spoke to inform this testimony, these are individuals that need care 24/7. They need reminders to take their medication, help bathing, and that is not something our health centers and with the partnerships with our shelters, that's not like a service that we necessarily can provide.
And then do you also have any other contracts for the street mobile outreach teams? Because I could see how that would be a great transition into your services as well.
Yeah, we do have some outreach teams, and I'm happy to talk more in detail about like our various sites and how each of them works. But yeah, we do have some street outreach that focuses on bringing people into assessment sites and drop-in sites and whatnot.
Perfect. And then just really quickly for Janine, right? Is that correct? Okay. I'm just curious to hear, what would your recommendation be for this? Because there's only, as you said, one program to really just declutter, but that's not addressing the actual issue, right? And so have there been recommendations from different advocacy groups that have said, hey, if you were to create this agency, or if we were to integrate some other models within, like, for example, DSS, or what have been some of the recommendations that you all have suggested?
So I can't speak to whether or not the recommendations have been formally made, and I can so I can get the actual name of the different kind of therapeutic models and things like that, and include it in my written testimony. But basically, in theory, this could happen under Adult Protective Services as well. So currently, if somebody is hoarding in the apartment, it's called a deep clean, and what it is it's just a junk removal service that comes in. I mean, not just, it's a big feat for the individuals that do that work, but we're also speaking about mental health diagnoses, and hoarding disorder is a clinically recognized mental health diagnosis. So there isn't any treatment provided or even clinical assessment. Well, perhaps there might be a clinical assessment in the psychiatric evaluation, but there isn't the related treatment for the individual, nor is what's carried out clinically informed, right? So they go in and they remove all of the individual's belongings. They can flag, a couple of nominal things that they want to save, but there are other processes that are more clinically informed. So one, there could be actual mental health support for the individual throughout the process, because it's very traumatic. So there's often underlying trauma that leads people to hoard, or loss, grief, things like that. And so it's often like a manifestation of something that they've already gone through. Then the process itself is traumatic, and then there's no ongoing support for them. So they also run the risk to hoard again and again, have all of their possessions taken from them. And if they don't, then they face either eviction, because that's often when we're seeing them. There's a holdover case. They're in housing court facing eviction. So it's either lose your home and end up in the shelter, or give up all your possessions. And unless you have a lot of means, so there are also companies that do work with clinicians, and you have to pay $5,000, $10,000. So you have to be a person of means to even engage with these companies. At times we have tried to secure funding for particular clients for this, but again, if we're a nonprofit legal services provider looking to find outside funding for $10,000, that's a really sizable amount of money. So it's really not available to a lot of low-income New Yorkers. Thank you.
Thank you all. Okay, the next panel is Ronald Johnson, Fiona O'Grady, Kumari Cruz, and Christopher Leon Johnson. They all came together, huh? Oh, these are all the Bronx people, she was saying. Yeah, they came. She said she
Yeah, I'm gonna go first because I got things to do. I know it's kind of. Can I go?
Go for it.
Yeah, hello, chairs Hudson and Lee. Thank you for having this hearing today. I'm here to show my support for Chair Christian's bill. And the reason I'm showing my support is because we have to make sure that the people that living on Social Security does not get their money cut. I have a big feeling that Donald Trump, who is our president, is doing this because he want to fund ICE. Well, at the same time, the reason I'm showing these posters, I hope I don't be called be off topic, is because of that. We have to make sure that ICE does not get funded with federal money. I'm calling the city council to make sure that they work together. They work with the speaker to Trump-proof New York City. I know you can Trump-proof New York State, but you can Trump-proof New York City by making sure that that Social Security is funded, no matter what happens. You could take some of this money out and help fund. You should make budgets to fund these older people. We have to make sure that we stand with our migrants because this is nothing but to hurt immigrants. They take his money out of Social Security just to fund ICE so they can deport the migrants, deport good migrants, not the bad ones, just only the good ones. So I'm calling the city council to really come forward and Trump-proof New York City, stand with our migrants. And one more thing about the mental health situation. What we need to do is to put an initiative, like a subcommittee in the city council to designate for young mental health. I mean, not only for older mental health. We need to designate a subcommittee. I hope that's our you, Mrs. Linda Lee, to appoint like Eric Botcher, who is here. He's not a committee chair. I think he should need to make a committee dedicated for young mental health. He's a millennial. I mean, he should lead that committee. Not only just for, I understand we got DYCD here, committee held by Alita Stevens, but at the same time, we have to have a subcommittee dedicated only for millennials and Gen Z. And I believe that Eric Botcher will be the perfect person to lead that committee. I hope you have that in next year's budget. So, thank you. I got to go downstairs for the rally.
Thank you so much.
Thank you. Yeah. Downstairs the rally, I go right down there. Yeah. Thank you. Sorry about that. That's why I went first. Thank you.
All right, I think we're on. Hi, good afternoon, and thank you, Chairs Lee and Hudson, for the opportunity to testify here today. My name is Kamari Cruz, and I am Director of our Public Education Program, as well as our Bereavement Services at Samaritans. In my role, I help to support those who have lost loved ones to suicide, and I help to train professionals across the city, including senior center staff, case managers, caregivers, on how to recognize and respond to suicide risk. We support Intro 1257 because it brings long overdue attention to how agencies are or aren't serving older adults living with mental health or neurological conditions. Our team often hears from seniors who feel like they're falling through the cracks. They're misunderstood, overlooked, dismissed by the systems that aren't necessarily designed with them in mind. But the value of this bill lies not just in the data it gathers, but whether that information actually leads to meaningful change. That change depends on the genuine engagement with those who understand the realities on the ground. So our community-based organizations like ourselves, other dedicated caregivers, as well as the older adults themselves. These resolutions 106A and 852 are also directly tied to suicide prevention. Financial security is a major driver for anxiety, fear, and distress, especially among older adults. This would help to protect against housing instability, which is a common trigger for crisis, while safeguarding Social Security benefits, ensuring that older New Yorkers can maintain not just financial stability, but a sense of dignity and independence. A person's worth does not diminish with age. We see oftentimes the misconception that aging and sadness are oftentimes going hand in hand with just lost my train. That it goes hand in hand with aging, depression. But every adult has a story. They have relationships and a right to support. Many of us feel Many of them tell us that they feel like a burden, that no one would notice if they're gone, that their pain is really just a part of getting old. And those are some of the huge misconceptions that we have to reject. And these bills help to do that. Every adult we speak to is a reminder that suicide prevention must extend across the lifespan. These proposed policies move us closer to that reality. Thank you again for your time.
Thank you.
Hello there. My name is Fiona O'Grady, and I'm Director of Government Relations working with Kamari at the Samaritans of New York. Chair Lee, thank you. You're very used to us coming to the Mental Health Committee for many years, but it's exciting actually to be here with Chair Hudson as the topic of aging and suicide is a very important one. And I think you have some of the stats are in our handout we just gave you, which is older adults tend to plan out suicides more carefully, and therefore they utilize more lethal means, and they also complete suicide much more than many other age groups. They're less likely to recover from an attempt. Older adults may exhibit passive help, self-harm behaviors, such as eating less, going out less, not doing things less. And so the misconception also that aging and sadness and depression go hand in hand, with aging, and as you've spoken all day, is a misnomer, and it reduces the likelihood of identifying risk. And we don't, or we assume that older adults, it's nearly okay. There's a discussion around suicide and getting older, but there's also suicide prevention. So both of these truths can be there, and we have to figure out where people are and to go to them, to where they, what need they have. So we strongly support Intro 1257, particularly for expanding eligibility for housing support and protecting social services. We also agree with the study proposed, but we do urge the Council to ensure it not only is robust but actionable, and that you start to include the word suicide with these discussions around aging. It is a myth, and it's a difficult word across all age groups, but I think especially for adults, because we think of them on their way to dying. Therefore, it doesn't seem to be so bad with them to be suicidal, but that's actually another myth and a misconception. So you all know us well. We're actually really pleased to be here with aging, and we'd love to interact. We did have some conversations with your legislative fellow during the budget hearings and et cetera. We would like to get closer to your staff and everything, and we will over the summer and autumn.
That sounds good. Thank you. Thank you both so much.
Good afternoon.
Just press the button there at the bottom. Yep.
Oh, thank you. Good afternoon, Chair Lee, Chair Hudson. I appreciate the opportunity to come before you. Although I have a personal testimony, I believe I speak for New York City correction officers, past, present, and the future, who were injured in the line of duty. It is an egregious ruling how the New York City Department treats officers that go in every day, put their life on the line, and they deny them full disability based on interaction, engagement, or altercation with an inmate. I myself personally was performing my duties as a New York City correction officer, and I suffered an injury, and I was denied full ability. I was denied full disability based on, I believe, arbitrary rulings, discriminatory rulings. I believe that correction officers already have a tough job. Many people don't know what goes on inside. I worked in Rikers Island, AMKC, which was the largest facility on Rikers Island. And correction officers, it's a thankless job. It's a thankless job. No one sees the ins and outs. And each day we walk into that facility with a uniform on, we put our life on the line. A correction officer is always in the line of duty, from whether you're doing 8 hours or 16 hours. So I believe it is totally unfair for the department to base a disability based on your engagement or interaction with an inmate. I beg of the committee to please look to somehow bring in legislation to change this, look at cases independently, because again, I know when I came in 1991, correction officers was primarily black and brown, and now knowing these stipulations placed on them, I can in good faith tell anyone, hey, listen, it's a great job now. Who wants to walk into a facility knowing that an inmate dictates your disability? And also with that, with these rulings, you put correction officers, civilian staff, as well as inmates in danger, because with these rulings, you're hesitant to act. And we know in that environment, you have little time to act upon a situation. So again, I thank you for hearing me. I believe this matter is important to all those officers who don their uniform every day, and I believe I speak for many of them. I speak to officers daily. I have friends now, and it's just egregious knowing the difference between full disability and what we would say 1/3 disability is dependent on engagement with an inmate. Thank you. I appreciate your time.
Thank you so much. Can we just get your contact information? You can come up to the table. And just,
right now?
Yeah.
Okay, thank you.
That way we can just follow up with you directly. We will now move to virtual testimony. Please wait for your name to be called to testify, and please select unmute when prompted. Saif Alam.
You may begin.
Yes. Hi. Good afternoon, Chair Lee, Chair Hudson, and everyone in the committee. My name is Saif Alam, and I'm one of the civic leaders in Jamaica Hills, Queens, where I work closely with community members, advocacy groups, and local organizations to uplift voices of our most vulnerable neighbors, especially seniors, people with disabilities, and working class family. I'm here today to raise deep concerns about the threats to Social Security, particularly following proposal from our current U.S. presidential administration that aim to cut or weaken this essential program. In Jamaica Hills, we have a significant senior population, many of whom are immigrants, retired public servants, essential workers, and caregivers. These residents rely on Social Security as their primary or only source of income. It covers their rent, medications, food, and transportation. There is no safety net beyond monthly check. If the federal government proceeds with any cuts to Social Security, our seniors in Queens, especially those in Jamaica Hills, will face real immediate harm. As costs of living rise and affordable housing becomes scarcer, any reduction in Social Security is not just unjust, it's dangerous. While Social Security is federally administered, I urge the City Council to take a clear and vocal stance. I respectfully ask you to pass a formal resolution condemning any federal to cut or privatize Social Security. Increase city-level supports for older adults, including outreach, to help them access their full benefits and housing protections. Fund legal and benefits advocacy programs so seniors, particularly immigrants and non-English speakers, are not left behind, and work with New York's congressional delegation to make the city's position clear. We will not accept cuts to a program that keep our communities afloat. Our
Timer has
cities.
expired.
Can you give me a few more minutes 30 seconds to finish?
30
That's fine.
seconds, absolutely.
Our seniors built this city. They worked in our cities, cared for our families, paved the way for the governments that followed. As one of the civic leader in Queens and Jamaica Hills, I feel a deep obligation to ensure we fight for their dignity, their security, and rightful place in our future. Thank you for the opportunity to speak today, and we look forward working with the council to protect our neighbors. Thank you.
Thank you so much. And I'd like to also acknowledge that Councilmember Salam has joined the hearing. Okay, I want to call the next few names that have registered for questions or for testimony, rather. Armando Rodriguez, Alex Stein, Gordon Lee, Dante Bravo. If any of you are online, please unmute yourselves and we will begin the countdown. Okay. Seeing no one online, we would like to close the hearing. Thank you to everyone who's provided testimony today. This is such an important topic, especially as we see the older adult population increasing by 40% in New York City here over the next 15 years. And thank you again to Chair Lee for her steadfast partnership. This hearing is